একটু সবাই can we kindly mute ourselves please? So I think we can start now.
Asif, are you live now?
Sir, we're live now, sir.
Okay. Over to you, Dr. Maziba.
Assalamu alaikum. A very good evening to you all. Welcome to Cataract Webinar series. This webinar has been jointly organized by Bangladesh Society of Cataract and Refractive Surgeons and Bangladesh Eye Hospital and Institute. So in this webinar, we will be going back to the basics, and we will try to cover the basics of phacoemulsification, and hopefully this webinar will be useful for the young surgeons out there. And we are very proud and honored to have with us rich panelists. They are not only good surgeons, they are excellent teachers. So we are going to learn from them. They will be sharing their expertise with us also. So at first, I'm going to introduce the panelists. We have with us Professor Mohammad Nazrul Islam, President of Bangladesh Society of Cataract and Refractive Surgeons and consultant of glaucoma and phaco at Bangladesh Eye Hospital and Institute. We also have with us Dr. Mohammad Shaukat Kabir. He is the Secretary General of Bangladesh Society of Cataract and Refractive Surgeons and Associate Professor of Ophthalmology at Bangabandhu Sheikh Mujib Medical University. We are proud to have with us Professor Soro Alam. He is the EC member of Bangladesh Society of Cataract and Refractive Surgeons and Director Education of Ispahani Islamia Eye Institute and Hospital. We are very happy that Dr. Abdul Rakib Tushar could join us from far above. He is the Vice President of Bangladesh Society of Cataract and Refractive Surgeons and Associate Professor of Ophthalmology at Barton Hospital. We are proud to have with us Dr. Ishtiaq Anwar. He is the Joint Secretary of Bangladesh Society of Cataract and Refractive Surgeon and consultant of glaucoma and phaco at Bangladesh Eye Hospital and Institute. But I have to mention something else. He is also supervising the Cataract Fellowship at Bangladesh Eye Hospital and Institute. We have with us Dr. Mohammad Mustaq Ahmed. He is the Organizing Secretary of Bangladesh Society of Cataract and Refractive Surgeons and Associate Professor at National Institute of Ophthalmology and Hospital. Professor Mohammad Shafi Khan is also here with us. He is the International Affairs Secretary of Bangladesh Society of Cataract and Refractive Surgeons and Director cum Chief Consultant at Lions Eye Institute and Hospital. Lastly, the speakers. I'm very proud to be one of them, and all the speakers over here have completed their long-term fellowship in cataract surgery from Bangladesh Eye Hospital and Institute, and now they are working at different hospitals around the city. So without further ado, we are going to start our webinar. Our first topic today is patient evaluation, the first step to reach the destiny. This will be presented by Dr. Roxana Rehnuma. She is working as a consultant at Bangladesh Eye Care Hospital. Dr. Roxana, will you please share your screen?
Is it shared now?
It's there, but
yeah, okay, I'm continuing. Assalamu alaikum. This is Dr. Roxana Rehnuma. Good evening, everyone. Thank you all for giving me the opportunity to speak here. Today, I will speak about patient evaluation.
Can you bring the second part of the screen, Dr. Roxana?
Yeah.
Go to the arrow in the lower left corner. There is an arrow.
So, is it shared now?
No, it's not. Share again, please.
Uh, it's showing my screen is shared.
Yeah, we can.
Yes. Now it's shared. We can
You have
see
to
the
open your
PowerPoint.
PowerPoint.
Okay.
Renuma, you
Yes.
have to open your
Yeah.
PowerPoint.
Yeah,
Now
PowerPoint,
it's there.
Now it's
Now
there.
to full, yes.
full.
So I will talk about patient evaluation, first step to reach our destiny. So proper evaluation and planning can help us to reach our goal. Doesn't matter how bad the road is. So why patient evaluation is so important? Proper patient selection for FECO, whether it is for beginner or for regular FECO surgeon, to anticipate and to prepare for possible complications and to predict FECO outcomes and clearly communicate with our patients. So to reach the goal, we have to touch 4 landmarks. One is history, second one is examination, third one is investigation, and fourth one is planning and counseling to the patient. So in history part, we take the history of vision. Usually cataract is associated with gradual dimness of vision, but if a patient complains about sudden blurring of vision, we have to think otherwise. In case of, we have to take contact lens history, we have to take other ocular disease like glaucoma or any allergy, we have to treat those cases first. Any ocular surgery like glaucoma or pterygium, we have to plan for incisions accordingly. And in case of any refractive surgery or retina surgery, we have to think about, we have to keep it in mind during doing biometry. And if a young patient comes with unilateral cataract, we must take history about trauma. Systemic history is also important. If a patient has history of diabetes mellitus or hypertension, it should be controlled, otherwise we will not go for cataract surgery. And drug history is also important. We have to take history about blood thinner and some drugs which can cause intraoperative floppy iris syndrome like alpha-1 receptor blocker, antipsychotics, antihypertensive, and we have to keep it in mind during surgery. So I will highlight what we usually miss during evaluation or evaluation. So before dilation, we frequently examine visual acuity, but we usually miss to take best corrected visual acuity. Pupillary reaction and RAPD examination is so important. If we get any abnormality in the pupillary reaction or if you get RAPD, so we have to think about optic nerve dysfunction and we have to treat that patient accordingly and counsel the patient. We have to also examine ocular motility. In external examinations, we have to examine like any blepharitis, any lacrimal drainage system pathology, or any ocular surface disease, or any lid pathology like ectropion or entropion. We have to treat those cases first, then we will go for cataract surgery. In case of slit lamp examination, meibomian gland dysfunction and ocular surface disease or any conjunctivitis should be treated earlier. This is a thick corneal ulcer. It is not suitable for beginners. So we have to think about that. Corneal endothelial examination is so important, and endothelium examination for keratic precipitates is also important. If we get a history of trauma, we have to look for iridodialysis as well. And we have to examine the anterior chamber. We examine, but frequently we forget to magnify and illuminate the beam so that we can find the flare as well as the cell. And anterior chamber depth examination is also important. Pupillary margin examination is also important. This is a case of mine where there was dandruff-like deposition in the pupillary margin. When I dilated the patient, there was pseudoexfoliative material over the lens as well. So pupillary examination is also important for nodules, and for surface of the iris examination is also important for nodules, and examination of the pupillary margin for neovascularization. So all these cases, after examination, we have to measure the intraocular pressure very carefully. Before, after dilation, intraocular pressure measurement can mislead us. So after dilation, it is very common improper grading of the cataract. So we follow LOCS3 classification for especially for nuclear sclerosis. This is nuclear sclerosis 1, this is 2, this is nuclear sclerosis 3, this is 4, this is 5, and this is 6. We have to identify the cortical cataract and mention accordingly. Now, this is very important to differentiate the posterior subcapsular cataract and posterior polar cataract. In posterior polar cataract, it is usually well delineated than the posterior subcapsular cataract, and there is plaque-like opacity and which is dense, discoid-like than the posterior subcapsular cataract. But if we get confused differentiating the posterior subcapsular cataract from the posterior polar cataract, we have to treat that as a case of posterior polar cataract. In case of white cataract, we have to differentiate it from the Morgagnian cataract because complication is more common in Morgagnian cataract, so we have to keep it in mind. In case of subluxation, if we do not get any subluxation, but we think that this might be a case of subluxation, we have to ask the patient to look towards the suspected direction of subluxation to evaluate it. We frequently miss vitreous cells, so we have to examine that. We have to evaluate the retina and optic disc as well. If we get any abnormalities in the retina or optic disc, we have to treat that case or counsel the patient accordingly. And now the investigation part, the most important investigation is intraocular lens calculation, that is biometry. And if we cannot examine the posterior segment because of dense cataract, we have to do the B scan. Now, planning and counseling, we have to give some special emphasis in some complicated cataracts like hard cataract. We have to keep OVD and we have to keep the capsular tension ring because zonular weakness is common in hard cataract. In case of zonular weakness or subluxation, we have to keep capsular tension ring and capsular tension segment in hand and also suture material to stabilize the capsule. In case of posterior polar cataract, it is very common complication. Anything might happen. So enough viscoelastic devices, anterior vitrectomy should be kept ready, and a 3-piece IOL should be kept ready. In case of poor pupillary dilatation, pupillary expanders should be kept ready. And in case of pseudoexfoliation, pupil expander as well as capsular tension rings should be kept ready and should be in hand. Now the counseling part. So after evaluating the patient, we have to counsel and give special emphasis in case of expected visual outcome. If there is any ocular comorbidity, we have to counsel the patient about IOL options, as there is a wide range of options nowadays, like monofocal or toric or multifocal IOL options. And if there is any complicated cataract, we have to counsel the patient secondary surgery might be required. So what is the ideal criteria for beginner? Eye should be well exposed, corneal endothelium and anterior chamber should be normal, pupil should be well dilated, and cataract should be at least grade 2 to grade 3. Patient should be mentally sound, overall general condition should be good. That is how we can complete first landmark of our patient evaluation. Thank you all.
Thank you, Dr. Ruxanda. That was a wonderful and elaborate presentation on patient evaluation. I would like to request Dr. Mohammad Mustaq Ahmed to give his expert comment on patient evaluation.
Thank you, Dr. Mahajiba. I am thankful to Bangladesh Society of Cataract and Refractive Surgeons and Bangladesh Eye Hospital for selecting me as a panelist. Thanks, Dr. Ruxana Ranuba, for your nice presentation of patients evaluation. If we follow all of this, I think patients will be highly satisfied. FACO is a very high-tech surgery having tremendous outcome. From my own experience, one of my patient having dense posterior subcapsular cataract, যে অপারেশন করার পরেই পেশেন্ট টেবিলতে উঠে বসলো, বসে ওর এক চোখ আধার চোখ বন্ধ করে সে বলল, স্যার আমি তো সবকিছু দেখতে পাচ্ছি, সবকিছু খুব ফকফকা। তো বললো, স্যার ইফ ইউ ডোন্ট মাইন্ড আমি আপনাকে একটা কোশ্চেন করি যে আমার পকেটে স্টার সিনেপ্লেক্সের একটা টিকিট আছে, আমি সিনেমা দেখতে যাইতে চাই। That is the patient's expectation. So patient expectation level is in case of phaco surgery is so high. So to fulfill this patient's such expectation, pre-operative evaluation should be very meticulous. Ladies and gentlemen, here Dr. Reanuba explained very elaborately about patient's evaluation. In history taking, patient's refractive status is very much important. Patient may be amblyopic, so we should take care about this patient amblyopic. It should be take care. In systemic history, for the patient safety, for patient's life safety, cardiovascular status, COPD, it is very much important. So if patient have any cardiovascular problem, we should keep anesthesiologist during operation for patient's life safety. In case of drug history, drug allergy is very much important if a patient have any allergy to drug. And another one which is explained by Ranuma very nicely, the alpha-1 receptor blocker using patient, it is very digested during surgery in some cases. So we should take preparation before operation. Own construction is very much important in that cases. If patient pupil is not oil dilated, it is better to use pupil expander. If pupil is dilated oil, in case of ovaries, is used optimally, and the parameters usually irrigation and aspiration flow rate should be maintained in low rate. In the case of cases, we may use atropine eye drop to 1 to 2 hours before surgery, which may keep the iris in a stable position. Then in case of examination, dilated slit lamp examination is very much important to evaluate the patient. If after dilatation of the full dilatation of the pupil, if we examine the patient by slit lamp, we get some information about the AC depth, about the nucleus grading, about the joinular status, by which we can take decision about our nuclear management. Another one is pupil dilatation is more important for beginners. And after that, we should examine the posterior segment for good post-operative outcome. We should keep in mind we must examine macula and optic disc head. In some cases, when there is hard cataract or dense posterior subcapsular cataract, it may not be see adequately optic nerve head and macula. In that cases, we must do OCT macula in diabetic patient, or we do OCT Gurguma protocol where this is not clearly visible before operation. Then in case of premium lens selection, patient's profession and expectation is very much important. Before premium lens, I will prescribe patient profession and patient expectation should be clear, and patient should be counseling properly. So thank you all. Thank you, Dr. Ranuma, for a nice presentation. Thank you.
Thank you, sir, for your expert comments. I know we will have a lot of questions on patient evaluation, so we will try to cover this at the end of the presentations. So our next presentation is on biometry. I will share my screen now. Is my screen visible?
Yes.
Okay. So today I'll be talking about biometry. And in biometry, when we go into the surgery, we are thinking, are we putting in the right power? Am I putting in the right lens? So in order to achieve the target, we need to understand biometry. And I will try to cover a little bit of biometry in my presentation. So at first, if we understand simply, biometry is IOL power calculation. And there are some requirements for it. At first, what I will need is the keratometry, that is the radius of curvature of the cornea, and the axial length of the eye. Apart from this, the newer formulas, which I'm going to discuss on later, they need some new data. That is the white to white, the AC depth, and the length thickness is also required in the newer formulas. So for measurement of the radius of curvature of the cornea, keratometry, there are many machines available. So we can get confused that do I get the manual? Do I use the autokeratometer? Even IOLmaster is giving us the K rating, or the topography. So the answer to this is whichever machine is giving us accurate, consistent result, we can stick to that machine. But to get that accurate results, we need to follow some guidelines. At first, that machine calibration must be done. Second, the most important part, no eye drops should be given before keratometry. Why? because when I instill the eye drop, what I'm doing is I am disrupting the tear film, which is part of the optical system. So the K reading that I will get will not be accurate. For this same reason, contact lens wearers should stop using their contact lens 48 hours prior to biometry, and the average K reading is around 42, 43. So if we get too extreme of a reading like 40 or 47, then we must recheck to see if we have got the correct data. And the same thing that we must do both eyes to compare between the two eyes. Why are we saying so much about keratometry? Because one diopter of error in keratometry can lead to a postoperative refractive error of one diopter also. Now let's look at the sources of error. They are very simple. Over here we can see that the patient, the forehead is not touching the machine, or over here the lateral canthus has to be aligned with the mark. So these small points can give us a good reading. Another thing I want to say is the tear film. There's so much importance of the tear film. If I tell the patient, look straight, apni chok bondho korben na, chok bondho korben na, what is happening? The patient's tear film dries up, and even as we can see that the Myers are getting distorted, and the reading I will get will not be accurate also. Next, let's come to the axial length that can be measured through many machines. There is the ultrasound biometry. We can do the contact or immersion method, and also the optical biometry, that is IOL master or Lenster. Again, whatever machine is giving us consistent result, we can start using it. But as we move to premium IOLs, it is always advisable to get the optical biometers because they are giving better results. Since we are mostly using the A-scan, I'll be just talking about that. First thing I'll have to do is give a target to the patient. Next, I have to see that my hand is stable. And lastly, alignment is very important. If these three things I can ensure a good scan. Lastly, I must have a good graph. So let's see what a good graph looks like. So in a good graph, all these 5 spikes, that is the first from the cornea, L1 and L2 from anterior and posterior surface of the lens, R is from the retina, and the last spike is from sclera. All these spikes must be present and they have to be of equal length. Now, why are we talking so much about the accuracy of A-scan? Because this is very important. Only 1 millimeter error in axial length gives out a huge 3 diopter of refractive error post-operatively. So we have to be very careful. And if we see some sources of error, the most common is corneal compression. If we can see here, these are the same patients. In the actual axial length and AC depth is 24.6 and AC is 3.2. But when I have compressed the cornea a little bit, let's see what happened. Axial length has gone down, AC has also gone down, but most importantly, let's see what has happened to the IOL power. The actual IOL power was 22. It has gone up to 23. So if I had given a 23 lens, I would have made the patient myopic. So I have to be careful about corneal compression. The second, as I was saying, that we have to hold the probe parallel to the eye, or else, as I was saying, that 5 spikes has to be present, but over here we can see that the scleral spike is missing. So this will also not give me a good result. And as I was saying, that studies have shown that now the optical biometers are giving good results. They are more accurate, and also that 1 millimeter corneal compression won't, since there's no compression, we won't get that error. And obviously the patient compliance is much higher with the non-contact biometers. And lastly, the latest biometers, that is IOLMaster 700, these are also doing good even in media opacities. And I hope this is visible. I just want to, this is just for the young surgeons who are beginning. At a gist, what should we look into? Number one, I have already talked about the spike. Next comes, this is very important, the standard deviation. The standard deviation should be less than 0.05. Only then I will know that my scan is accurate. Lastly, what other information can we see from here? The axial length, as we have seen, we can see here. The main important is the K1, K2. the difference of the K1, K2 is my cylinder or astigmatism power. Over here, I can see the difference is 1. So this patient is definitely a good patient for toric IOL. Next two things to keep in mind is what formula to use. I will be talking about it later. And lastly, over here, we can see that A constant is present. So what is the A constant? This is specific for each lens. So I need to be careful. Whatever lens I want to put in, I have to put that A constant in my formula. So first and second generation formula we are not using now. I will talk about the third generation, which we are minimum we should use the third generation, that is SRKT, Hoffer Q, Holiday 1. If we want even better to use the fourth generation, that is Holiday 2 and Haggis. These three formula, the third generation, all works very good for average axial length of 22 to 24. But if we have a very long eye of more than 26 millimeter, then SRKT is the choice. For eyes between 24 to 26 millimeter, Holiday 1 is our formula to use, and for shorter eyes, Hoffer Q is what we should use. But the fourth generation all works good for all types of axial length. But then the question comes, do I have this formula in my biometry machine? How am I going to use it? To answer this question, Dr. Barrett has helped us a lot. What he has done is, in this, he has put his formula available online free of cost. We have just to go to the APACRS or ASCRS website and we will find the formula over there. I'll just show a short clip of how to use the formula. So going to Google, typing in APACRS, formula today I'll be using is the Barrett Universal 2. I must accept the disclaimer. Now let's start calculating the data. There are some data we must put in, that is which lens I want to put in. Next, why I chose Universal 2, because as you can see, this was a hypermetropic patient. His axial length was 21. So I know that I need a proper lens power calculation for this patient. So, and as I was saying that we always should do biometry of both eye, and even in these formulas, we can see that they want both eyes. So this is how much importance both eye biometry is. Next, I'll just press calculate and it's giving me how much IOL power should I put in. And as I can see that both has come to 26.5. And I'll just share a study. This is by Savini et al. It came out in JSCRS in January of this year, that the newer formulas have much more accuracy. So we should all opt for using the new formulas. Two special cases that now we are getting very much post-LASIK cases are coming. Again, Dr. Barrett has done it for us. I'll just go in the APACRS website and I'll type in the Barrett True K formula. This is for post-refractive cases. And I'll just put in the data we have and we'll get a good result. Another I want to discuss is silicon field dye. What happens in silicon field dye? We need to just change the velocity of the vitreous. In that case, we will get the actual result we want. And before I end, I want to say that there are some things we need to keep in mind. Number one, that no eye drops should be used before keratometry, and mostly check before I put in. Suppose my K reading, we have seen this happen, the K reading was 46, but instead 64 was put in. So we need to be careful about it. Next, the correct IOL formula. According to the axial length, we need to choose the formula, and according to the IOL I'm going to give, I need to choose the A constant. With this, I want to say that most of the errors, they are not technical, they are mostly human errors. So these all can be avoided. And I want to end by saying that if we just put a little mind in our biometry, we are going to hit our target bang on every time and give our patient the desired postoperative refraction. Thank you. So I'll stop sharing my slide. I'll request Dr. Abdurraqib Tushar sir to give his valuable opinion on biometry.
Thank you, Dr. Mahajiba, for your excellent presentation, and thanks Society of Cataract and Refractive Surgeon and Bangladesh Eye Hospital to give me an opportunity to talk about this webinar. First of all, the biometry is the key point, because in a total, the outcome of any surgery, any cervical surgery, credit goes always to the surgeon, but in background, a lot of people involved, like making a cinema. So to get a best outcome of a cataract surgery, it needs a lot of support from the supporting staffs. So I highlighted 4 points. Like first one is that depending the best result of biometry, it depends on first is machine, which machine you are using. Second, the technician who usually do it for the surgeon. Third is the patient's particular anatomical situation. And lastly, the surgeon's personal experience. So always it is recommended that when a cataract surgeon start his journey, his or her journey to do the cataract surgery, he or she should track record what are the after surgery our refractive target we are usually achieve, and then he can personalize that what type of machine he or she is using, and what are the outcome after doing the biometry. My personal opinion is that if it's possible, go for the best one, that is optical biometry. If you don't have any optical biometry machine, at least go for the contact biometry with immersion technique. This is 2 recommended point. One of the point Dr. Maziba already touched that things, the calibration of the machine. We should calibrate the machine every week. If it is not possible to do every day, you should do it in every week, and train the technician, particular technician, to do that, how it calibrated and how they do this biometry and the tricks of the good biometry, like Dr. Maziba already touched that things. If the keratometry reading is below 40 and above 47, he or she should check double that the keratometry is okay. They can compare with the manual keratometry with auto refract, then do it by another person, that is it in a human error or not. That is one thing. Second thing is that if the axial length is below 21 and above 24, definitely both eyes should be checked and repeat the test. And even if the patient's tear film is not okay, because sometimes we see a patient dilatation, measurement of the intraocular pressure, and then we decide to go for cataract surgery for tomorrow, and that time we advise the patient do the biometry, but it is not recommended. If possible, to do a biometry in a situation when any other procedure are not done. That is, no topical drops or other things. Lastly, the best way to get the formulas. My recommendation, if we do all the biometries outcome, put a Barrett online calculator. That is the best thing we have now, and we can get the best result. And what I heard from the other expert cataract surgeon all over the world, they do all the biometry in Barrett and do it in the toric calculator. Because why I said the toric calculator, what Dr. Maziba said, if the difference between the keratometry K1 and K2 is more than 0.5, they should go check with the toric calculator. If the online toric calculator by Dr. Barrett shows that the patient needs a toric IOL, we should go for that toric IOL. But in a situation in Bangladesh perspective, always we cannot afford, the patient cannot afford the toric IOL, but we know that a patient needs a toric IOL, and that way we can minimize the post-operative astigmatism, or we can counteract the pre-existing astigmatism by selecting the different axes, the higher the incision in the higher keratometry reading position, and by this augmentation and modification, we can get a good post-operative outcome. In last, I share my own experience, the horrible experience I faced due to the biometry error. I did it is around 5 years back. that time, so one or two patients, post LASIK patient, came to me to get a cataract surgery, and I asked for his pre-LASIK keratometry reading, and he did the LASIK in India, but he could not get that results. So I look online, a lot of resource as possible, and I follow the SUMS K formula, and the refractive outcome is horrible. It's +4 postoperative refraction. So it teach me that it should be very meticulous to do, because when you do a hard work by good surgery, your skill, your everything, and just due to some error in doing the biometry, it gives a horrible situation like me. So be careful. And in our situation, follow the tricks, what Dr. Mahajiba said, and you should get a good outcome in post-operative situation. And thank you, everyone. I am at present is exactly 7,696 miles away from the Dhaka, with passing good time with my family, and I have to leave because there is an preoccupation. Thank you, sir, and thank you, everybody. Thank you, Dr. Ashraf, Dr. Mahajiba, and everyone to give me an opportunity. Thank you all.
Thank you. Best of luck, sir.
Thank you, sir, for joining. Thank you, sir.
Thank you.
Thank you, sir, for joining us and giving us a little of your time, and also for sharing your experience. And now we are going to enter the world of the surgery. So at first we have Dr. Ashfaq Rahman Khan. He is a consultant of Bangladesh Eye Care Hospital, and he's going to be presenting on incision, the gateway to a mysterious world. Dr. Ashfaq, please share your screen.
Is it sharing?
Yes.
Yes.
Make it full screen, please.
Assalamu alaikum. It's a privilege to be present and as a participant in front of my esteemed and honorable judges, panelists, and my co-presenters. My topic is the integral part of the phacosurgery, which is the incision. Incision is the gateway to the mysterious world of the eye. And incision, it can be compared with the game of chess. You know, the game of chess is in the game, you have to be perfect with every move and calculate each move beforehand. Like that, in phacosurgery, our incision should be pre-planned, and as well as this move can lead to the perfection. Why it is so important? It is important because it affects the fluid dynamics during the phacosurgery. IOL implantation affects astigmatism and wound healing, sometimes the risk of infection and endophthalmitis. Now, ideal incision, it consists of a side port. After doing the side port, we have to fill the anterior chamber with viscoelastic substance. Then we ensure the tightening of the anterior chamber and proceed with our main port. The ideal incision should be self-sealing, astigmatically neutral, and sutureless. Now, a common procedure, which is side port. In case of the side port, we have to ensure that the blade goes in the same direction, same plane, as well as during exit point in the same plane, so that no enlargement of the incision is done. A common complication during the side port is a long tunnel, which is shown in this video. Now, before going into our main incision, there are some videos that I like to show. If our incision is too tight, it may lead into wound burn. If our incision is too wide, then it can leakage our fluid from the anterior chamber, from the side port, as well as the main port. If our incision is too long, then it's difficulty in manipulation in anterior chamber. If it is too short, then there is a chance of iris prolapse, like in this video is showing. In case of a posterior incision, there is a chance of the conjunctival ballooning. And so the main incision, it depends on incision location, architecture, and incision closure. Incision location, it can be again circumferential and radial. In circumferential, there is temporal and superior approach, and in radial it is scleral, limbal, and clear corneal. First, I like to let you know that our emphasis is getting the surgery done on the temporal approach, but in case of the beginners or those surgeons who are upgrading their surgical skill from SICS to phaco, they can start with the superior approach. Temporal approach has different advantages in comparison to superior, and it is more ergonomous for the small lid fissure and deep brows. Also, it can decrease the against the rule astigmatism, which is common in case of the elderly patient, and lower the surgically induced astigmatism. Same thing for the radial incision. There are three types: scleral, limbal, and clear corneal. We always prefer for the beginners to go with the clear corneal incision, but in case of the surgeons, those who are preferring the SICS and upgrading their surgical skill into phaco, they can start with the scleral tunnel, so that in any kind of facing difficulties, they can easily convert the method into SICS. Now, after scleral tunnel, the limbal incision, it shows same. It has the advantages for the beginners, also the surgeons who are trying to improve their surgical skill and converting into phaco. Now, most important and ideal incision is the clear corneal incision. In clear corneal incision, it is important because it provides a bloodless surgery. Those patients who are on blood thinners, uh, it is very much helpful for them. It is cosmetically good and also preserve the conjunctiva and the sclera, so that later on any trabeculectomy and any other procedure needed, it can be done easily. Now, incision architecture. Incision architecture basically depends on the width and length of the incision and internal contour. The width actually is the proportion between the keratome size and the sleeve size. First, you have to look what sleeve we are using in our phaco tip. Depending on the sleeve size, we have to choose our keratome. Keratome size can depend on 2.2, 2.4, and 2.8. And the length of the incision is also important. It should be parallel to the iris plane. If it is too short, then there is chance of the wound leaking. If it is too long, then there is difficulty in manipulation into the anterior chamber. So the ideal length should be 1.5 to 2 millimeter. It should be self-sealing, and it will help us for good instrumental access. Now, internal contour. First, I like to start with the triplanar, which is the most promising for the beginners, and they must start with the triplanar because it has a property of the self-sealing wound, which can help during and after the phaco surgery. And biplanar also, it is a good with two plane there, and it also has a self-sealing property. And for the expert one, there is a single planar entry. Now, astigmatism correction. Astigmatism correction can be done with our incision. If in our biometry, the K1 and K2 difference is less than 1 astigmatism, we can easily correct it with the incision to the steep axis, and after surgery, doing another incision at the opposite of the steep axis up to 0.25 to 0.5 diopter can be corrected in this way. Now, some common complication that may occur in case of the incision. The complication here shows the sudden thrust to the anterior chamber leading into the injury to the anterior capsule. Again, another common complication is long tunnel during sudden entry. Without proper holding, the long tunnel occurs. And some special situation, we have to adjust our original position of the incision from because of the pre-existing nasal and temporal pterygium. We should always pre-plan and evaluate the patient and plan our incision accordingly. Now, wound hydration is one of the important steps in case of the phaco surgery. Most of us do not pay enough attention to wound hydration. We should not overhydrate the wound. Adequate wound hydration must close all pores that we are using, and ensuring that is a good wound hydration can lead to a beautiful result. And the common complication during wound hydration are the decimate detachment. In here, a beautiful surgery done. After that, during the hydration of the side port, there is decimate detachment occurring. Same goes for this video also. Now, importance of suture. If we have any doubt in our mind during surgery that our wound integrity is lost, it may be pre-existing condition like prior vitrectomized eye, prior trabeculectomized eye, or shallow AC, or we can enlarge our incision more than 4 millimeter, and the wound is not sealing, then we should always give us important to keep our ego aside, beside, and do the needful for the patient, because a happy patient makes a surgeon happy. Thank you all.
Thank you, Ashfaq, for letting us getting into the mysterious world and showing us the gates to the mysterious world. I would like to invite Professor Shafi Khan sir to please comment on this presentation.
Thank you, Dr. Ashfaq, for a nice presentation. Incision is a very important part in phacosurgery. I will share what I am telling now. It's from when I was a phaco trainer in Islamia. I've seen many trainee, what the problem they have faced. First thing is that in our training period, we always prefer the scleral tunnel for the beginners so that they can easily convert to SICS or ECC like this. So it can be a choice, but nowadays we prefer that everyone should learn the clear corneal incision. So I will not go for the scleral tunnel. Clear corneal incision is more preferable in many ways. So where do we give the incision? It is total clear corneal or near clear corneal. We will prefer it is near clear corneal, just at the in front of the vascular arcade. That is a nick of the vasculature. What is the importance? It is nearly less astigmatic, and for healing purpose, it is more gives strength after 1 year or so on. Sometimes we found that after 1 year in a totally clear corneal incision, we can open it, reopen it just with a blunt instrument. But if it is near the vascular arcade, it's too tight and need to reopen, you have to introduce a sharp instrument. So nowadays we say that it is better to give incision just in front of the vascular arcade, touching the vasculature, not touching the vasculature, because it will create problem with the bleeding tendency and other things. And now come the how you form your incision. It is single plane, dual plane, or triple plane. Now I say that it is better for double plane, dual plane, not the triple plane. Sometime in triple plane, in previous days, trainer asked them that when you say dimple, then you enter. But nowadays, we don't prefer it, because in most of the cases, when you want to do with a dimple and then entry, it will create a leaky wound. Sometimes if you are too superficial, you will create a chevron-like entry point, that is angular entry point. And when you say an angular entry point, most of the time it is leaky wound. So better go for double dual plane or single plane. Then come, where will you choose the incision site, whether it is temporal or superior. Those who are converting from SICS to phaco, better to start with superior, then supratemporal, then temporal. And if you are not comfortable with temporal, it is very less difference between temporal and supratemporal. So you can go for supratemporal also. Now come with the water tightness of the wound. This water tightness depends mostly on the size of the architecture of the wound. It is better to, your length should be 2 to 2.5, and it should be square. Or if you use 2.8, then it may be a rectangular. But preferably the wound should be square, and it is 2.2 to 2.4 most of the time. And if you use a little bit larger lens like Indian lens and other lens, then 2.8 it is fine. It doesn't matter. And another thing is the depth of the incision. It should be half and half. That is half superficial and half posterior, half anterior, half posterior. If it is too superficial, most of the time it will be leaky. So the depth is another important thing. And another, finally, what Ashfaq told, that after completing the surgery, if you find the wound is not watertight, then it is better to give a single suture. so that it will be watertight. On the first period, you will find almost 6.9 to 6.6 vision. So thank you, everyone. It's a nice webinar, and the presentations are very nice. So thank you, everyone.
Thank you, sir, for your wonderful experience comments. And now we are going to move on to our next presentation. Our next presenter is Dr. Sharifa Jahan Mitu. She will be speaking on a very important topic. This is the first hurdle that a beginning surgeon faces, that is capsulorhexis and hydroprocedure. Dr. Mitu, please share your screen.
Assalamu alaikum and good evening. Thank you for involving me. So, a capsulorhexis is the one which leaves the signature mark of a phacosurgeon in a patient's eye. We cannot proceed forward without a continuous rhexis. A lot of queries come to our mind at the beginning. What is ideal capsulorhexis? It should be central, continuous, circular of around 5 to 5 millimeter, and should cover the optic edge of the IOL circumferentially. Why we should do a good capsulorhexis? It prevents PCO, IOL tilting, decentration, anterocapsular fibrosis or phimosis, and it holds the perfect effective lens position when we use the premium IOL. How can we do? Most of us usually use cystotome. In a 26D needle, we have to make the first bend near the base in an obtuse angle, and the second bend near the tip. It should be 1/3 to half of the bevel end and less than 90 degrees, so that when we are doing the rhexis in the anterior chamber, we can see the tip. It should be attached with the 1 cc syringe. We can also use forceps or microrhexis forceps for doing capsulorhexis. Here I'm showing a video of our trainee. See, the focus is not in the anterior capsule, and the tip of the cystotome goes beyond the anterior capsule, and it just causes the rhexis to torn apart, and the nucleus also popped up without hydrodissection. So what happened there? Is the lack of proper focusing, depth perception, and binocularity. That's why microscope orientation is a must before surgery. So how can we do an ideal rhexis? After proper focusing into the anterior capsule, fill the anterior chamber with the cohesive viscoelastic. At starting, a puncture should be made at the center, then cut radially, then push it forward to make a flap. Use viscoelastic substance if necessary, because we have to keep the flap flat always. Then the tangential pulling of the flap, change in the direction at a specific point, and smooth transition at the end are the secret to get an ideal rhexis. We may also use capsulorhexis forceps. I made the radial tear with the cystotome first, then grasp the edge of the cut margin with the rhexis forceps, and then pull it to make the rhexis. Grasping and re-grasping is the key to make a successful rhexis here. It is very easy to get an extended rhexis. First, we have to change the direction of the flap inward, then pull from the edge towards the center. Once the direction is changed, then we can do the rest in usual fashion. How can we manage if the rhexis becomes smaller? In the first case, you can see we can cut in one end and extend it before the further step. Or we can extend it after IOL insertion. After giving visco, cut one end, then extend it with the forceps. Here, visualization is very important. In a small pupil, I sometimes do rexes under the iris. Here, the tangential pulling and judicious use of visco is the key factor. But every time I cannot be fortunate enough. Here, my rexes got extended under iris and rest was history. So what I do usually in a small pupil, I do rexes 1 millimeter less than the pupil size in a mid-dilated one, or use of pupil expander before doing it. In a white cataract, the biggest fear is the runway rexes due to the high intralenticular pressure. Sometimes I do a single rexes or orange peeling one, but I always use strip and blue before doing rexes here. Double rexes I feel is the safest way to do among all. Here I did the smaller rexes first, washed away all the loose cortical matter under the capsule, then gave visco, cut tangentially a little, and then did the second rexes. Is double rexes absolutely safe? No. See here, my rexes got extended while doing the second one. So I cut from the opposite side and then make an distant side rexes. In a fibrotic capsule, the pearl is we have to start opposite side from the fibrotic zone. Then we have to cut where there is adhesion underneath and complete slowly because there may be pre-existing zonular weakness. It's always a challenge to do rexes in a subluxated cataract. Here, I first make puncture with the cystotome and then use forceps to start from the opposite side of the weak area. As a part of the lens was obscured under iris, I use iris hook to make the part of the lens visible, then complete it slowly. Then the hydro procedure. In the beginning of my phaco training, I was always taught that no hydro, no rotation, no phaco. Why hydro plays such pivotal role? Because it separates the cortex from the capsular bag, so we can easily rotate the nucleus and do the nuclear management, and it also helps for easy cortical aspiration. How we can do it? We can use BSS with the hydro cannula or J-shaped phoneal cannula or visco cannula attached with 1 cc or 3 cc syringe to do a dissection. 1 cc is better because it gives us controlled dissection. Here, what is ideal? First, we have to remove some visco from AC, then go below the rexus margin, lift up a little, and push a jet of fluid and see the complete fluid wave. Then pressing in the center and repeat it to the opposite side. Why we should press in the center? Because the fluid behind the lens comes up through the other side and dissect the cortex from the back completely. Once the dissection is complete, then we can rotate it with the Sinskey or plain spatula. I rotate usually 2 to 3 o'clock once and then in the opposite side to confirm it. When we inject a gush of fluid at a time and inadequate central tapping, what happened? Here, the nucleus popped up. And if we see here, see a sudden constrict and subsequent dilatation of the pupils. See again. And deepening of the AC and iris is prolapsed. That means my posterior capsule has been ruptured. It is called pupillary snap sign, the sign which we don't want to see. And here, if you can see, here is a tag in the rexus margin. When we try to do the forceful hydro here, what happened? The rexus got extended. So we have to be very gentle to handle those rexus. Sometimes we do hydro delineation where a small amount of fluid is injected in between the nucleus and epinucleus so that the posterior cortex acts as cushion to prevent posterior capsular tear, especially in the posterior polar cataract. Here the golden ring is the confirmatory sign to complete the delineation. Sometimes I do both delineation and dissection, especially in a very soft cataract, only PSC or something like that. Delineation helps for nuclear removal and dissection helps to rotate it comfortably. In a cataract like hard or white or small people, I'd like to do multiple site small dissection, like small amount of fluid should be given to prevent iris prolapse or posterior capsular tear. When life gives you lemon, make it lemonade. See here, one of my colleagues started this case. The rhexis was small and there is so much pressure on rotation, and during sculpting, see how much rocking of the nucleus. And the end result is zonular dialysis. So I have taken over the case, gave CTR, and then iodine bag at last. So in summary, learning the basic is like the baby steps. We have to be master on that first, then learn how to run. By managing the different type of cataract, we may stumble with complication, but go through that with patience and you will be the winner at the end. Thank you.
Thank you, Dr. Mitu. That was a wonderful and elaborate presentation, and hopefully our youngsters will learn a lot from it. I would like to invite Dr. Ishtiaq Anwar to give his expert opinion.
Assalamualaikum and thank you, Dr. Maziba. I congratulate Dr. Ashraf for arranging this seminar, and it's so nice to see. I mean, I have seen all of the presenters today just grow from no surgeon to better surgeon than any of us. So congratulate to all of them. And Mitu has presented everything so nicely, importance of rhexis and rotation. And when we take fellows, one thing I say that rhexis is actually not part of a phaco. If we think that way, that it requires no phaco machine, and but it is such an important step that whenever we take any application to from any part of the world for the trainees, we say that you must become expert in rhexis and then come here, because otherwise you will be wasting your time to do just learn phaco and then go to the phaco proper part. And if nobody can do a good rhexis, the next steps become very harder. In eye surgery, what happens that if we make a mistake at any step, all the steps forward is going to just become very difficult. So at the beginning, like Ashfaq said, if you make a mistake in the incision or rhexis, all other parts is going to be so difficult. And what I would say that, practice in wet lab or on tomatoes, huge amount of practice should be done before we go to human eyes, because patient safety should be the first priority. And what we teach and advocate in our center, and I would also request all of them who are learning that do stepwise. First try giving a nick in couple of cases, then lift the rhexis, do about 1/4 or half, and then gradually, when you are confident, complete the rhexis. And one thing Mitu was saying that, cystitome or forceps. In our part, we use OVD maximum is the HPMC, which is not thick as the other OVDs like Hilon GV, which we don't have in our country. So if we introduce a forceps, more OVD comes out. So it's logical for us that we use cystitome while we are using, but there are some expert surgeons, as Professor Nozrul is here. Nozrul sir, he's going to say that he is very comfortable with cystitome as he has learned it that way. So OVD, I think one thing I would add to Mitu's presentation is use a heavy OVD while doing rhexis. And if you think that AC is getting shallow, come out, inject, but we should never inject too much of OVD, because if we inject too much of OVD, that flap of the rhexis, there's a possibility that it will come out. And also, if we inject too much of OVD, there is chances of iris prolapse. And one thing that there is a technique called Little's technique. If the rhexis is extended, we should pull it towards the center rather than going to the periphery. I think Ashraf has a video you can collect from Dr. Ashraf, and we all should learn this little technique. It's on YouTube. So it's a very good technique to recover runaway rhexis, or which is going towards the periphery. And regarding rotation, I would say that I still rotate with a spatula. I don't want to force rotating. If the hydro is good, I feel it should rotate, I will rotate it. If it's not rotating, don't force the rotation, rather do hydro in other 2 or 3 places, multi-quadrant hydro. If it still does not rotate, we should proceed with the sculpting and other things, and eventually it rotates, but we should never force the rotation. So overall, thank you and very nice presentation.
Thank you, Dr. Ishtiaq. I know that the surgeons this will help the surgeons a lot in their practice. Now we will move on to the next presentation. Our next presenter is Dr. Ashraful Hokridoy, and he will be presenting on nucleus management.
Is my slide visible and I'm audible?
Yes.
Thank you, Dr. Maziba. Before I starting my talk, I would like to express my gratitude to Bangladesh Society of Cataract and Refractive Surgeon for co-hosting this webinar. And my special thanks to Professor Dr. Nazrul Islam sir and Dr. Shaukat Kabir sir for their support. The goal of nucleus management is to remove the nucleus safely without any damage of the capsular bag, zonules, and the corneal endothelium. So we talk about how to remove the nucleus, but we have to keep focus on the zonules and also the corneal endothelium. We need to focus lens fragmentation. That includes the proper groove and separation and cracking, emulsification, hand stability, where my phacoprobe is, and overall the patience of the surgeon and the belief that yes, I can do it. That is the focus and belief. A phacosurgeon needs to understand phacofluidics, and the nucleus management planning depends on the cataract grade, cataract type, and pupil size. How I tackle my nucleus is important, as well as the phacofluidics. What is my machine parameter? Maybe we will discuss in the next webinar. So the many techniques are now established for the successful nucleus management, but I shall focus the basics. The most safe technique is divide and conquer. We make 2 grooves, thus separating the nucleus into 4 pieces. When we sculpt, we focus on the length of the sculpting, which should be within the rhexis. The sculpt length should not go beyond the rhexis, and also the width of the sculpt, that the phacotive and the sleeve can travel through the lens smoothly, and the depth of the sculpt, how deep we will make the groove. For sculpting depth, we need to follow the curvature of the back of the lens with phacoprobe, go downward up to the center, and then proceed upward. So we will get a boat-shaped groove. And the bevel part of the phaco tip should be upward because I want to see what I am doing. And the depth perception is very much needed to avoid this such complication. Look what happened here because of the lack of depth perception. For the soft cataract, the trench should be narrow. That will help for cracking. And it should be perpendicular, that the 2 groove. And in soft cataract, we can easily see the fundal glow. And the proper depth is achieved, and that will help us to smoothly crack the nucleus into 4 pieces. The phaco tip and the cracking instrument should be placed at the base of the groove. Otherwise, it will create pressure on the zonule and the posterior capsule and go for complication. In little heart cataract, the trench should be little bit wide, and there is the reduce of bulk of the cataract so that I can easily crack it. And sometimes it is difficult for adhere lens fiber. For that, we need the layer by layer separation. We need to be patient, not more separation. A little bit layer by layer separation is needed here. And we have to keep in mind that when we go for this focus, it should be the complete separation. And for this, we need to remember that the good depth and good construction of the groove, and for cracking the place the tip on the base, and we need to crack at the point of highest resistance, because if we place our instrument at the soft part, it could go for the cheese wearing and it could harm the capsular bag. And for that, we need to have the right movement of the instruments, and we need to focus the complete separation of the fragments. For emulsification, bring the fragmented piece at the center first. Don't do emulsification at the periphery. When we bring it at the center, then we chop it and do the more fragmentation. Then we can emulsify the small fragments. It will make our phaco very easy. For beginners, this is the always advisable and good practice to fill the anterior chamber with OVD before the last piece removal. For stop and chop, we sculpt one trench. Then I prefer to divide it manually into two hemi pieces. And when it divides into two hemi pieces, then I chop it and make it 4 to 8 pieces as my comfort to emulsify it easily. And here I am showing the horizontal chops, and always we need to focus on the instrument what we are using. That is also very important. In case of direct chop, we divide the nucleus without making the trench. I prefer it for Morgagnonian cataract. It's very easy to do the Morgagnonian cataract with direct chops, but keep in mind, when we are doing the direct chop, it could cause the zonular damage and the back damage for the very hard cataract. So we need to have the expert for doing the direct chop. And after the technique, we have to beware about the few situations that never hold with the phaco tip at the base of the nucleus while chopping. Always hold at the middle part. Look it again, we hold at the base and the PCT occurs. So always hold at the middle, and I told previously, emulsify when our phaco tip is in the center, is in the safe place. And also never give too pressure for lateral separation. And this is the cross separation. We should avoid it. We should maintain the equator for separating the nucleus. Otherwise, this complication will be very common, and we lost one of the piece of the fragment in the vitreous. And always maintain the proper phaco-dynamics and right movement of the phaco probe. The phaco probe should be stable and at the center when we emulsify. If it just push and it just pull, we just catch the capsule and go for this complication. And lastly, for the beginners, I would like to say, be expert in divide and conquer. I would like to show my gratitude to my mentors that they taught me that be expert in divide and conquer, then stop and chop. If you become expert in divide and conquer, eventually you will become in stop and chop and every other technique of the nucleus management. Appropriate sculpting depth and complete separation is needed. Emulsify the nucleus at the capsule or anterior capsule or the Irish plane, not too high, not too deep. And the phacofluidics and proper instrument positioning is very important. And also the judicial use of power. And while we are doing phaco, we have to be in mind that focus and believe. I have to focus of my nucleus management, and I have to believe that, yes, I can do it. And last of all, this is my favorite thing, what I always tell, the surgery is all about control. We need to maximize our control by just moving the interphalangeal joint, not the wrist or not the hand movement. And we need to be perfect in every steps of surgery. Thank you very much.
Thank you, Dr. Ashraf. That was a wonderful presentation on nucleus management. I would like to invite Professor Nozrul Islam sir to please give his valuable opinion.
Thank you, Dr. Majiba. First of all, I'd like to thank Bangladesh Eye Hospital for co-sponsoring along with the BSCRS. And on behalf of BSCRS, we'd like to thank Bangladesh Eye Hospital chairman, MD, and all the consultants. The presentation was very nice. Dr. Ashraful Haq has covered nicely all the points of the nucleus management, starting from divide and conquer, then stop and chop and direct chop, all the methods he has shown. And he has shown the use of viscoelastics, especially the OBDs, when to use, how. Also the dynamics, pharmacodynamics, fluidics, also he has covered. Thank you for that. I think every step of the phacochemistry is very important. The last two speakers, I congratulate them. They also spoke very nicely. The incision, capsulorhexis, everything is very important. And if your previous step is good, then your nucleus management becomes comparatively easier. And for the nucleus management, it depends on what are the grade of cataract you are doing it. Is it a soft cataract? Is it a 2-3+ cataract? Or is it a hard cataract? Or it is a kind of brunescent cataract. So everything depends on your density of the cataract. So first of all, divide and conquer is the very standard method. And I think when we learned phaco 23 years before, we started with divide and conquer. Still, we teach our doctors, junior colleagues, the divide and conquer first. And it is really a universal technique that we can learn and we should learn correctly. Even in my practice, I do divide and conquer maybe 1 or 2 months one case, because in a very hard cataract, that is still the safe method. Whatever method you tell, but it is still the safe method. So we still do it. And very important part, Dr. Ashraf already shown that you must know how much groove you are doing, how much your depth, how to understand the depth. There's two ways. One is the consistency sign. That is, you are going a hard cataract, going, and then suddenly you will feel your nucleus's consistency changed. So that is, you are going towards epinucleus. So that is very important. And another important is your color, is the retinal color, sometimes the fundal color you will see. So that is very also important, that you have gone up to how much depth you have gone. And Dr. Ashraf rightly said, you can go up to the rhexis margin, never go more than that. And it should be very equidistant. It should be such a 4-quadrant that looks like a screwdriver, the Phillips screw. Somebody calls the Phillips screw like that, cross. And if you make a good cross, if you make a good depth, the cracking is really easy. And if you feel difficulty in cracking, then it is better to sculpt more and go a bit more detail. Otherwise, it is difficult to crack. Do not give any pressure. If you give pressure, that could be zonular dehiscence. And another important thing is your twin instrument must go deeper, not in the superficial. If you make it superficial, it will not crack. So go to the deep. It's very important. Second point is the stop and chop. I think ultimately in due course, after doing few hundred cases, you must learn the stop and chop. That is the universal method. Still we are doing stop and chop, because if you make 2 halves, then this 1 half you can make either in middle 1, then make 2 halves, or you can make 3, 1, 2, 3. And you can make the whole thing, this stop and chop is the easy way. And for that, you need to know the fluidics, because during the stop and chop, you need to hold the nucleus so nicely that you can divide it. So here the fluidics is very important. Your holding power, your vacuum should be such good in always in foot position 2, so that you can hold it nicely and you can crack it. So stop and chop, until you are not holding it in position 2 correctly, you cannot do it. So it is very important to hold the nucleus and do stop and chop so that you can crack it nicely. It's very important. In the direct chop, I think it is the job of a master. I salute who can do it, but it is sometimes in the very, if you want to say that I don't want any complication, it is really difficult to do direct chop, because direct chop sometimes might have some complication. But if you make a stop and chop, it's not problem. What I do in my practice, most of my cases, I make a hole, very small hole in the in the superficial part, maybe towards my side, and make the hole maybe 1 or 2 scalp. That's not enough. then go for the direct chop. So that helps you to go to the depth. I don't know how much depth it is. So you can understand the depth it is and go to the depth and go do the direct chop. That is the best way ultimately you will have to learn. And definitely when you can learn most cases, definitely you can learn the direct chop, and that is ultimately the final outcome of a phacosurgeon. Maybe within few years we'll find that everybody is doing direct chop. That is our goal, of course. Regarding one thing, OBD, I must say that depending on the density of the cataract, you must use your OBD. If it is very hard cataract, try to use the dispersive viscoelastic. Try to coat the endothelium. If it is in a like the eye care hospital, OBD here, viscot is not available. Definitely, you can use the methyl cellulose frequently, so frequently that your endothelium becomes not burned. To next day it will be more clear. So these are the few things I think very important for the nucleus management, and we must take care in a special situation like posterior polar cataract, like zonular defect. Then you should be very careful. Posterior polar, you cannot do hydrodissection, you can do hydrodelineation, you cannot do a regular crack. Sometimes you can take the periphery, then you take the whole nucleus out, and then you can emulsify. So there are some different, grammar is different in your different situation. In very soft cataract, you simply make a very narrow trench and divide mechanically in two halves, and then emulsify it. It is very easy, and never go with the very high powered phaco. It is not possible in case of very soft cataract. So these are the few things you must think of: your density of cataract, your fluidics. And nowadays in Bangladesh Eye Hospital, of course, you keep in mind that we have also femto laser. So in case of post-polar cataract, in case of very hard cataract, this femto laser also helps us for the nucleus management. I'd like to again congratulate Dr. Ashraf for a very nice presentation. And it was really a good thing to learn all points on the nucleus management. Thank you very much.
Thank you, sir.
Thank you, sir, for your wonderful expert comments. I know that all the surgeons will definitely use your comments. Now that we are almost at the end of the surgery, but we need to end the surgery safely. So for that, we will go to our next presentation. Our next presenter is Dr. Sarah Rahman. She will be talking about cortical cleaning, safe technique, safe landing. Dr. Sarah, please share your screen.
Is it okay? Can you see this?
No, it's not shared.
Okay, just a minute. Now is it okay?
It's coming, but the presentation is not open as yet. We can see the presentation. We can see your folder.
Now?
No.
No?
Double click on the presentation, then it will open.
I have opened it in my laptop is showing.
No, it is not sharing here. Double click here.
Is it okay now?
No. Sarah, can you just close this and again try to share? Close this.
Yes, that is better. You close everything and then again share again.
Sarah, what you can do, you can just minimize the zoom first and open the presentation in the desktop, and then you can share.
Dr. Sarah, are you there?
Yes. Can you?
Okay.
Can.
No. Share your screen.
Dr. Maziba, meanwhile, this
No.
time.
Let's. Yes. We can see it. It's there.
Yeah. Okay.
Go to presentation mode.
Go to full screen, please.
Okay now?
Yes.
Yes, it's fine.
Assalamualaikum. I just want to share my gratitude to Bangladesh Eye Hospital and also BSCRS to give me this opportunity, because all the speakers here are my mentor and I am greatly privileged to be here. So today our topic is actually going back to the basics. After doing a fantastic removal of the nuclear management, as my previous speaker Dr. Ashraf has shown, when the shore is very near, we can see the shore, we just don't want to sink our boat and scream like, oh no, what happened just now. So when we go to the study, we can see that most of the posterior capsule rupture, especially for the beginners, occur during the cortical removal. Posterior capsule rupture rates in the hands of the resident has been reported from 0.5% to 16%, varying according to their experience. Clinical investigation into the posterior capsule rupture in phacoemulsification operation performed by the surgery in trainees, PCR was more likely to occur in the IA phase in the first 100 cases of the trainee. It is almost 27 cases, that is 4.5%. It is shown in a journal of ophthalmology. So we have to be very careful during this IA period or cortical matter removal, because after doing the nuclear management, it is very sad to have a PCTR in this stage of the surgery. So today, my topic is cortex removal, safe technique, safe landing in the phaco surgery. I am Dr. Sarah Rahman, working as a consultant ophthalmologist at Bangladesh Eye Care Hospital, and currently I am working as a fellow in the Ispahan Islamia Eye Hospital, long-term cornea fellow. The importance of the appropriate cortex removal. It reduces the risk of inflammation, reduce the risk of intraocular pressure elevation, and less chance of posterior capsule opacification. Different type of instruments are here used, like the Simcoe cannula, coaxial handpiece, and the bimanual handpiece, which is nowadays most available and safer technique. There are some prerequisites for the IA. We use foot pedal, position 1 for irrigation and 2 for irrigation and aspiration. Also, the phaco-dynamics, that is vacuum, aspiration flow rate, and the irrigation. These are the basic prerequisites for the cortical removal. So this machine parameter is for the bimanual technique. The irrigation should be in between 900 to 90 to 100 centimeter of water, and also vacuum in between 250 to 300, and usually we use the linear vacuum because it gives a good control to the surgeon. And the aspiration flow rate should be in between 25 to 30, or we can use 28. For the coaxial cortical removal, the vacuum needs to be a little bit higher, that is in between 300 to 350 millimeter of mercury, and the aspiration flow rate is also a little bit higher, that is 30. And this is for the Centurion machine. Here the intraocular pressure is parameter is there 40. So usually aspiration is in between 25, but we need a high vacuum, that is 400, rather than the our Infinity machine. So cortex removal safe technique, it is just like a poem.
So when we learned from our institute, we actually do it like a poem, like always enter the irrigation port first. First of all, we have to form our anterior chamber, then the aspiration port. And we have to go underneath the rexis margin and see the cortical matter properly. And it is like this, and there is a lower portion and upper portion of the cortical matter. We have to hold the upper part of the cortical matter. So great focusing is very important. Then hold the cortex and press just foot pedal 1 to hold it. Then tangential movement to remove the cortex and pull it centrally, then press full 2. So this was a video of the APA series. It got the best award for video section. Here we can see if we do a radial cortical removal, how much pressure is there over the jonule. So usually we use the hurricane technique, or also known as tangential method, and there is almost no pressure over the zonule when we use this hurricane technique. So this is our video. See how smoothly the cortical matters are removed without any pressure over the zonules. So this is, we are using a coaxial technique and tangential technique. There is no radial pressure over radial cortical turning towards the center. Advantage of using a bimanual technique: safer and easier removal of the lens cortex, easy to remove the subincisional cortex, because with the coaxial we know sometimes the training period of the beginning training period we have some hurdle to took the subincisional cortex with the coaxial method. Less risk of wound distortion, and it is easier for the small pupil, because for the small pupil we can use the irrigation port to just remove the iris a little bit so that we can see the cortical matter. So this is one of my video for the bimanual cortex removal, just going underneath the rexis and hold the cortex and then pull it tangentially towards the center and then emulsify it. After doing half of the side, then we have to change our port and then do the opposite half. So complication during IM. This is a very common complication. Just this is a classic animation. Just through the phaco probe, we touch the posterior capsule. See, so we have to just go to our reflex or release the foot pedal. Then no mishap will occur. But if we panic, then PCTR could happen in this stage. So this is another video of our institute by one of our colleagues. Just after doing this surgery, very small piece was there, and see there is a small PCTR there. Oh, so we should use viscoat if available, and in-bag IOL can be given in this small PCTR. Show this video, the anterior chamber is not formed and the visualization is not clear, and you see there is a vitreous tag through the phaco probe and there is a large PCTR here. So in this case we have to do the anterior vitrectomy and we can give a PMMA or a multipiece lens in the sulcus. So zonular dehiscence or dialysis is a very common complication. In this video, see there is a clean cut zonular dehiscence through the aspiration port. In this case, usually we give a CTR and then in-bag IOL can be given. Polishing is very important because by polishing, usually we remove the lens metaplastic cell that will later on cause posterior capsule opacification. So a small polishing can reduce the chance of PCO. So during this polishing, the parameters are usually very low. This was one of my case tragedy during polish. This was a 20 years old boy. He is very myopic. Power was 15 diopter. And after completing all the surgery, I was doing the polish. So just see what happened. Oh, a total bag came out, and I was like, had a heart attack then, because the total, almost total bag came out during the polish. My vacuum was only 10. So anything can be happened at this last stage of the surgery. So I just put the viscoelastic in the bag so that bag go to its position, and instantly I put a CTR. And also it was a paid case, and the lens was preloaded Oro view. So this was another lesson for me, that if the patient is very myopic, there could be pre-existing jonular dehiscence, and this could happen even in polish. So you see, it was preloaded lens, I told you, and the haptic came in another fold, and I thought that why this has to happen in this case, but it happened. Then I put some gel, and this haptic change its direction, and then it was okay at last. So the post-operative vision was okay. Um, Visco removal. So we always learn from our mentor that OVD is the surgeon's best friend during the surgery, but it also can cause postoperative IOP elevation if we do not remove this viscoelastic properly. So for a proper viscoelastic removal, usually we go underneath the lens using our irrigation cannula, so that all the visco are came out, and usually the vacuum is higher in removing the visco elastics. So the take home messages are: bimanual IA is a safe and easy technique. Hold the cortex and move tangentially with a very low vacuum, and gentle steady smooth movement is necessary. At the end of the day, phaco surgery is an art, and we want this smile to our patient. So safe landing is very important by doing safe technique in the cortex removal. Thank you for patient hearing.
Thank you, Sarah, for showing us how to land safely after the phaco surgery. I'd like to invite Dr. Mohammad Shaukat to give his valuable opinion.
Thank you, Dr. Majiba and Dr. Ashraf, and also our President, Professor Nazrul Islam sir, for giving me opportunity to give my valuable opinion on Sarah's presentation, and also uh, give us opportunity to jointly co-host with Bangladesh Eye Hospital. I also like to thank you, the authorities of Bangladesh Eye Hospital, for giving us such opportunity. First of all, I would like to thank Dr. Sarah for nice presentation. Actually, she gives every bits of the IA irrigation aspiration, and rightly present the whole thing. Hello, can you
Yes,
hear
sir.
Ashraf?
You're audible.
How to hold the cortex underneath the capsular axis, and put it toward the center, and then how to clear the cortex. And she also explained the whole thing, like we should care about. First of all, there is, we can use the coaxial or bimanual method. I usually do coaxial, but bimanual is better, always better, and but I'm accustomed with that. Uh, and for there is removal of cortex, one thing, then the removal of viscoelastic. It is also important because nowadays we are usually going behind the eye well, especially for at the lens, and especially for the premium ions, because it is mandatory. Otherwise, it will give us to some complications like rise of IOP, and sometimes there is for toric lens there is rotation, and for multifocal there is the displacement of the lens. So I would like to thank Dr. Sarah for covering all aspects of the education expedition, and like to thank you all for hearing.
Thank you, sir, for your wonderful comments. Now we will move on to the next and the last presentation. Since the surgery is almost over, let's go and put in the IOL. So for that, we have our next presentation. It will be on IOL implantation, and our next speaker is Dr. Mahmoud Rashid Chaudhry.
Dr. Maziba, one thing, the director of the Institute of Bangladesh Eye Hospital, yes, Professor Zalal Ahmed sir is with us, and he will be joining in the panel very soon.
It's very good. Thank you.
Are my screen visible?
Yes, it is. Please go on.
Yes, thank you. Assalamu alaikum. At the beginning, I want to thank BSCRS and Bangladesh Eye Hospital and Institute for giving me the space to talk. And I'll be talking on IOL implantation. Although Dr. Sarah has already landed, but there is still something more to be done. Actually, after all the hard work, incision and nuclear fragmentation and cortical aspiration, when IOL is put safely into the eye, it brings always a joy for the phacosurgeon. But if there is complication in this stage, it creates a sad moment. So our focus will be on IOL loading of different types of IOL and their safe implantation technique in this basic phaco of IOL implantation. So the first video is on IOL loading of a normal monofocal acrylic lenses that we commonly use. First, we give visco into the cartridge, and IOL is taken from the IOL box and put over the cartridge, and care is taken that both sides of the optic are into the groove, and also both the haptics, and no part of the IOL is within the flanks of the cartridge. And be careful always to get rid of the bubbles. Then we put it on the eye, and a second instrument is put on the side port so that IOL does not rotate. Usually IOL comes in like just like English word 7, it will come from the injector into the eye, and then a gentle rotation is done. But what to do when IOL comes out wrongly, not the usual way that we intended. So just see this video. IOL has been put into the bag and it rotated. So it turned the other way. So what will we do now? We don't have to panic. You just put visco and use 2 instruments to reverse it and bring it in the normal position. That's it. And now we will see the loading of premium IOL, monofocal Alcon IOL. Here we see the leading haptic has been bended a little bit, and the IOL is introduced into the cartridge, and the tailing haptic is also bended and put it over the optic, and it is moved forward as far possible. Sometimes we need to put multi-piece IOL. Different companies are available like Alcon and the AMO, so the loading is different as because the haptics are different. So if we see it, the Alcon 3-piece IOL comes with a B cartridge. B cartridge has a protruded part behind at the posterior end of the cartridge, and we will see later how it helps us. The IOL is gently placed in the cartridge. We take care not to damage the optic, also the haptic. Now the important part is the trailing haptic. We will put this trailing haptic on the left side of this protruded part, just like this. Then the rest of the thing is normal. We put in the injector and we'll put it in the eye. The sensor multi-piece IOL is little different because the cartridge is different and also the injector is different. So there are few techniques that we can follow. First, the cartridge is fixed, filled up with disco. IOL is put over the cartridge as previous. Both the optic will go under the groove and leading haptic will be within the tube. And the trailing haptic will remain outside, just like this. This is one technique. And make sure that the leading haptic is seen in the front tube. So in the next technique, we put the IOL from the posterior end, a little different from the first technique. The rest are same. Leading haptic will go into the tube and the trailing haptic will come out. So during placement in the injector, the plunger should be taken back as far possible, and then cartridge is placed, and the trailing haptic should be on the left side of the injector. If it does not stay so, then we have to put it manually on the left side, just like this. The idea is to not to damage this trailing haptic with the plunger when the plunger pushes the IOL. And we push the IOL as almost at, up to the tip of the cartridge, about 1 to 1.5 millimeter behind. Sometimes we face that during implantation, the IOL is not coming in the usual way. It is coming rather in the wrong direction, as we will see in this video. So at that time, what we will do? See, the IOL is not coming the way we intended. It was coming the other way around. So here we can rotate the injector just like this, so that the IOL comes now in the normal position. And when all the optic has been delivered into the bag, then we can make the injector straight again. It most commonly we face in case of 3-piece IOL this type of problem, so it's a good thing to follow. And this video is taken from YouTube, and the rest of the thing is normally we just gently dial the IOL into the bag. So now we'll see some IOL related complications that we commonly face. First one, the IOL gets stuck in the wound. So quite a sad situation for the surgeon. And second one, trailing haptic is engaged in the cartridge. Creates a problem. And third one, very fast IOL insertion, the IOL hits the other end of the cartridge at back and creates posterocapsular tear. So we will be very gentle in all these steps to prevent all these complications. So in take-home message, we have to keep in mind some few points that don't let your assistant to load the IOL all the time. Just take a few minutes to load by yourself. Load IOL under microscope, it is very important. And leading haptic must be in the back, which will give you an excellent advantage. And be always gentle and steady and controlled movement while implantation. Before ending, I want to thank Dr. Ashraful Haq, Dr. Sarah Roman, and Dr. Mitu Jahan for sharing their videos with me. And thank you all for your kind attention.
Thank you, Dr. Mamoon, for your wonderful presentation and for the wonderful end of the surgery. I would like to invite Professor Sarah Alwan sir to please say a few words. Mamoon, can you please stop sharing your screen?
Thank you, Dr. Ashraf. Bangladesh Eye Hospital and BSCRS for allowing me to comment something in this forum. Actually, before commenting, I want to say something because I'm witness of about 500 training of 500 ophthalmologists of Bangladesh. And I'm very delighted to see the amount of knowledge, amount of expertise in surgery and presentation by the juniors today, which was unbelievable in our days. When I was first trained in 1996, when we returned, we saw the condition that seniors are not allowing the juniors to come near the microscope. Now nobody will understand. We have to fight for it. Seniors not allowing any juniors to give any presentation. They will only present and juniors will only listen. Even during my postgraduate training, I saw one registrar was locking up the slit lamp in his room so that nobody can touch it. So the juniors must feel how blessed they are nowadays to have this type of opportunity of getting training. We must also admit that juniors are more smarter than us and they're picking up all the things so nicely and efficiently. About the training, actually, there is no alternative to structured training. Everybody will understand. And I can give an example of Johir Raihan. In one of his interview, he said that I was used a technique after thinking 1,000 times that in the same screen, the picture of the heroine will come 1,000 times. And he used it in some Urdu cinema. And he's told that after that, after few years, I went to Paris and I saw that this was taught in the lesson of a teaching institute in the very first month. So if he could went there, he could have learned without much problem and much delay. So that is the main beauty of the structured training. And in the structured training, we must emphasize the role of wet lab. And simulation is coming later. It is more costly simulators, but wet lab, I have seen among my trainees who has spent more time in the wet lab, they are doing better in the OT. And in the wet lab, I will not tell her name. One trainee has done all the steps of cataract surgery in Gorsai, though it is not possible. She has done iris prolapse, she has given stitches, she has explanted IVL, implanted every step which is possible. And she is one of the best phaco surgeons. She is now in government service. And there are so many old things are coming to my mind that when I returned in the next OSB in 1996, I saw a paper. One senior was giving a paper, presenting a paper that he is doing surgery in 100 cases, giving average IOL, that is 21, which now juniors cannot think of nowadays. And the surgical training and non-surgical training is different. So for surgical training, devotion of the trainers and the trainee must be different, because for a simple error, there will be a great change of many things. And also on the part of the trainers, they have to be committed, because it is not so rewarding thing. And people usually don't want to come to this trainer role. But if we don't create more surgeon who will occupy the situation when everybody older people will go. And one thing I must emphasize, you should do the orthoptic test of the trainee. We have few examples that after entering into the training period, we have seen much difficulty that they cannot orient even after maximum possible teaching. Then we have done the orthoptics. Then we saw that there was a great problem in their orthoptics, and we have given some orthoptics exercise, but somebody could continue, somebody couldn't. Even in some of our training, we found that there is a posterior subcapsular cataract, and he went to Basavada at that time, and he got surgery done. And actually, the surgeon must smell what is happening in his surgery. Like the জেলেরা যেরকম একটু সমুদ্রে গিয়ে বুঝতে পারে আজকের আবহাওয়াটা কেমন হবে, especially the nucleus management, who is described beautifully by Dr. Ashraf. And when he is inside the eye handling the machine, which is a little fault will be more unforgiving, so he has to be more careful at that time. So each step, as Ishtiaq has told, that each step of the surgery is detrimental, and a simple mistake will cause problem in all the subsequent steps. And a novice or very unskilled surgeon can do complication in each step. In my days in Arvind Eye Hospital, I have seen one Indian. He has done precedent while giving the final stitch after completion of the surgery. How raw his hand was. So we need to teach them in every aspect. And in Mamun's lecture, it is nicely, he has shown the different techniques of insertion and other thing. But at the end of the surgery, we should see whether it is inside the bag or not, even if needed by iris retractor or some retractor, because many times, even with some seniors in postoperative dilatation, we have seen that one haptic is outside the bag. And during introduction of the IOL, definitely all the surgeon has noticed the Indian IOLs are actually very difficult. Initially, when we first inserted, not knowing how the pliability is, suddenly it snaps open and directly went into the vitreous. So later on, we understood that these are not like Alcon and other lens. So this is in short. I can comment on each step, but everybody actually knows all the details, and they are very good surgeons. They are very knowledgeable, and I congratulate everyone. It is very nice meeting, and it will be helpful for everybody. Thank you.
Thank you, sir, for joining us and for sharing your experience, because your talks are always an inspiration for us. And now I'm very honored to have with us Professor Jalal Ahmed, sir. He is the director of Bangladesh Eye Hospital and Institute. He is the former president of Bangladesh Society of Cataract and Refractive Surgeons. And also, he is one of the faculties of our Cataract Fellowship Program. Sir, would you please say a few words to us? Sir, please unmute yourself.
Thank you, Dr. Maziba, and Bangladesh Society of Cataract and Refractive Surgeons, President Professor Nazrul Islam, and Secretary Dr. Shaukat Kabir, and all the speakers and panelists. For the last about 2 hours or more, I was deeply engaged in enjoying the lovely, amazing presentation by Rehnuma regarding evaluation. I think her evaluation is more, at least not less than me. Then Dr. Maziba's biometry. It is so important. She has pinpointed that where we can do wrong in doing biometry. Then regarding Ashfaq's incision, he has shown such a nice way that how the incision should be, ideal incision should be, and what wrong can be done with incision. And then Dr. Mitu's rhexis and hydro procedures. So nicely she explained the rhexis and hydro procedures with their complications. And then Dr. Ashraf's nuclear management, so nice and so lovely. Uh, I was deeply engaged in all the surgeons' presentations. So nice talk by by our young generation. Then Dr. Sarah, the cortical cleaning, so nicely cortical, so nice cortical cleaning. And during her presentation, she has shown that mm, in within a moment, complication can arise during cleaning of the cortical matter. And lastly, Dr. Mamun has shown how the IOL should be implanted inside the eye, and there are so many ways of implanting the IOL, and there are many different IOL have different cartridge and different injectors, and it should be properly given. So phaco is the eye is a very delicate structure. Professor Equisam Harun, I was with Sir for many years, and Sir usually used to say that eye is a very delicate structure. Handle it with very carefully. Handle it carefully. Eye is a very delicate structure. So when we are inside the eye, mostly either in the anterior chamber or in the posterior chamber, our wholehearted vision, visualization, focusing the microscope, the brain, the hand, and the legs, whole body should work in such a careful way that our 1 second's misattention, not not just forget. Just 1 second misattention can make a big mishappening. So I am privileged that all the presenters, close with all the presenters, both from Society of Cataract and Refractive Surgeon, and also from Bangladesh Eye Hospital and Institute, and all the I am grateful to all the arrangers, the Bangladesh Society of Cataract and Refractive Surgeons, and all the panelists for their nice discussion. I think I must thank, and I am actually proud of all the speakers from Bangladesh Society of Cataract and Refractive Surgeons and from Bangladesh Eye Hospital and Institute. Thank you all. Hope you will be in future, and their presentation are no less than any presentation outside the world. Whether you go to India, whether you go to America, whether you go to Europe, their presentation is parallel to most of the presentations outside Bangladesh. So thank you all for your nice arrangement and delivery. Thank you.
Thank you, sir. Your words are always inspiring us. Thank you so much for joining us.
Okay, thank you.
We are almost at the end. So we have a few questions. The first question is that when someone wants to switch from SICS to phaco, what should they do? If one of our expert panelists can please answer this. Professor Nuzrul Islam, sir.
Thank you very much, Dr. Majibra. First of all, I'd like to welcome Professor Jalal Bhai, because he has come and he has contributed this webinar very nicely. And he is not only Director BAS, he is also our advisor of the BSCRS. So most welcome here. Thank you for your comment also. Professor Sarwar also have given so nice comments, and so many comments are from himself. It is really nice. And I like to say, I have given a comment in the beginning that today we have 7 rising stars in Bangladesh. So actually they are really star. And I like to give all the credit to also to Dr. Shtiak, because he's the director of the Bangladesh Eye Trust Hospital. He has shown them the way of learning. And with the other panelists and other people, they helped us. That is true. But we are really proud to see our youngsters doing so good surgery, doing so good presentation. Definitely, it is amazing. And I have few questions. I will come later. Dr. Maziba has if a person want to switch from SICS to FECO. Yes, first of all, I think must learn. Dr. Ishtiaq also told we must learn capsulorhexis. Every surgeon, ECC or SICS, doesn't matter. They must learn the capsulorhexis first. They should learn also the hydrodissection, delineation in the SICS, no matter. They should prolapse the nucleus, and without enlarging the capsulorhexis, they will try to deliver the nucleus in the SICS. This is the first. And second thing is they should go in their incision a bit anterior, then they can go to the small incision. This is the best way. And if anybody knows the capsulorhexis, I think the FECO is very easy for them. It's not at all a problem. In my case, I learned FECO first, and after 3 years, I learned SICS. So that has been reversed. But anyway, if you learn really SICS, the FECO is comparatively easy. The best tips is to learn capsulorhexis. Very, very important. Thank you.
Thank you, sir. Uh, um, if Dr. Ishtiaq can join us and tell us a little about the cataract training program, it will be helpful for everyone.
The cataract program that we have in Bangladesh Eye Hospital and Institute, our trust hospital is the training center where we have beautiful facilities of wet lab, and this wet lab was co-sponsored by Alcon, and we have a FECO development program with collaboration of Alcon, and we were the 5th country in the world to have this program. And this has been designed by many of the reputed heads of the FECO fraternity, Dr. Vasavada and Dr. Panet. And so we were the 5th country, and I would say that this is one of the best structured training course in the world to learn FECO. And this is a stepwise approach, and so we'll be teaching not only FECO but FECO dynamics and all the steps that we had presentations on, starting from the how to select a patient. You know, this is such a important thing, that what sort of patient we should start with, and to treat the eyes of a patient like our own parents' eye, so that we don't do any harm. And I think there are some other centers also that have started doing FECO training and have established wet labs. But I encourage that, many of our pioneer surgeons had learned FECO by themselves. There were not such good facilities in our country. We had to go outside. For myself, I had to spend 1 year to learn just one surgery. All my family members and everybody was laughing at me that you're going to spend 1 year just to learn one single surgery. But it's so nice facility over there. I would say that not only in Bangladesh Eye Hospital, there are many centers in Bangladesh now. Of course, National Institute of Ophthalmology is the Apex Institute. There is a training program there, Islamia Eye Hospital and Institute. But I would request all that go through a structured training program. And Bangladesh Eye Hospital and Institute has one of the best structured program. And I invite all the juniors that if you want to learn in a proper way, join this institute.
Thank you, sir. So we are almost at the end. If any of the panelists would like to share anything.
I like to really thank from my core of my heart to all the speakers. By name, if I say Renuma has done so nice, and Dr. Maziba, Dr. Sarah, Dr. Ashfaq, Dr. Mitu, everybody, Dr. Mamun, everybody has spoken so nice that no many questions in our mind. That is really important. That is very important.
আমার একটা কথা ছিল স্যার একটু
বাংলায় I like to thank our panelists. Really, they have contributed a lot. They have contributed a lot. Dr. Mustaq, Dr. Shaukat Kabir, Dr. Professor Sarwar, Dr. Shafika, Dr. Ishtiaq, everybody has contributed to this webinar. It is really basic. We have not gone so far, but if we know up to this, I think to be a FECO surgeon is not at all difficult. we can go many ways, many far, many difficult surgery we can do if we know up to this basic. So thanks to Bangladesh Hospital for arranging this webinar along with the BSCRS. From my side, as President, as Secretary, we'd like to thank BS also. Thank you very much.
স্যার একটা প্রস্তাব ছিল স্যার,
Yes.
এখানে ওএসবির আছেন, মোস্তাক ভাই আছেন, এই ধরনের বেসিক নিয়ে আমাদের ওএসবি প্রোগ্রামে কিন্তু খুব একটা দেখি না, যে বেসিক একদম বেসিক কনসেপ্ট নিয়ে এভাবে ভিডিও সহ প্রেজেন্টেশন, সেটা যেন নেক্সট ইয়েতে ওএসবি প্রোগ্রামে থাকে। এই মোস্তাক ভাইয়ের প্রতি আমার আবেদন।
থ্যাংক ইউ সাবিকান। আমাদের লাস্ট যে কনফারেন্স ছিল ওখানে কিন্তু ছিল আশরাফ ইবিদার নেতৃত্বে একটা সেশন ছিল কিন্তু বেসিকের উপর ইয়াংস্টারদের নিয়ে। So I am very much happy. So 7 youngsters like a rainbow. They are really very much. Though they are young, but they are so mature about the FACO, and I also learned more from them. Thank you all. Thank you very much.
Thank you everyone.
Thank you everyone. So we will like to end now, but before ending, I would like to remember one of our mentors who had passed away 2 months back, Dr. Jahangir Alam Mukul, and he was there with us from the beginning of our career. So he's not here, but he will always be in our hearts, because every surgery we do, his mentorship will always be there. So with that words, I would like to end this webinar, and I would like to invite all of you to our next webinars. The next one Friday, which will be on which will be hosted by Bangladesh Eye Hospital Chattogram, and the next after that on 13th Saturday we will have a webinar. We will be switching our topic and we will be going towards cornea. So I'm inviting you all for those webinars, and I'll be end now. Thank you all.